Okay, Duchenne Care UK's guidelines on cardiac care have recently been endorsed by NICE. And to tell us all about them is Dr. John Bourke, who's consultant cardiologist and senior clinical lecturer at the John Walton Muscular Dystrophy Research Centre at Newcastle University.
Thanks very much. Now, I'm very conscious as I start this talk that some of you will have heard a lot of what I'm going to say already, but don't give up. Repetition isn't always a bad thing, but I want to bring everyone up to more or less the same level of understanding so you can see something of the logic as to what we're recommending. These are my disclosures. So the basic problem in Duchenne dystrophy, as I'm sure many of you are aware, is the absence of the protein dystrophin that's genetically determined. And if you just take this cartoon, the bubbly bit across the middle is the membrane of the cell. And, oops, beg your pardon. Dystrophin is the protein here sitting between the internal contractile elements, say, of a heart cell or a skeletal muscle cell, and linking it to the outside of the cell. So cells that don't have dystrophin are uniquely vulnerable to damage. They're basically unstable mechanically. And you can think about them in this sense. So right from the very beginning, heart cells, skeletal muscle cells are deficient in this protein. And that essentially leads to day-to-day cumulative damage to muscle cells, leading to inflammation, over-swamping of repair mechanisms, leading then to loss of muscle power and ultimately loss of function. There are no stem cells, that's cells that generate new heart cells. There's no heart stem cells, so that reduces the capacity for repair. In skeletal muscle, there are stem cells, so there's an important difference there. So you'll have heard already and are aware of multidisciplinary care, and you'll be pleased to know that after many, many years of arguing for this, cardiac care is now part of that. But essentially, I'm not trying to persuade you that cardiology is the most important bit, but just to say that multidisciplinary care, it's only as strong as the weakest link. And essentially, in adulthood in Duchenne dystrophy, the vast majority of deaths are ultimately dictated by cardiac and lung effects of the condition and muscle weaknesses in those areas. So one of the things to be aware of is you'll be fully, especially those who have children beyond a certain age, will be fully aware of the deterioration in skeletal muscle function and the implications of that. And there's a progression, I'm talking now about untreated, of course. But the heart goes through the same process, but with a lag time of about 10 years. And unless you're aware of that, and also aware that there are no symptoms of that, then you'll forget that the heart is involved at all. It won't bring itself to your attention in the way that skeletal muscle effects do. It's not a separate disease, not a separate condition, the heart involvement. It's not a question of whether a boy with Duchenne dystrophy will develop heart muscle weakness or not. It happens in everyone. So again, it's important to realize that from the start. But let's stand back a little bit and try and remind ourselves what we're trying to do. We're trying to, for patients and families looking after boys with Duchenne dystrophy, we're either trying to cure, ideally, in the ideal world, or maximally modify the natural history of the condition. And obviously, we need to bear in mind, whatever our interventions are, it mustn't impair quality of life. It should actually boost quality of life. But one of the key points to bear in mind, based on what I've told you already, is that preserving heart function for as long as possible is essential to maintaining long-term survival in Duchenne dystrophy. And the way to know how your heart is doing is by regular schedule of assessments. And that's done by echocardiograms. I'm sure many of you are familiar with that. That's an ultrasound imaging of the heart. And that's on the left. And on your right is cardiac magnetic resonance imaging, a more sensitive, somewhat more difficult to access and slightly more arduous test. Now, if you look at the process of heart involvement in Duchenne dystrophy, you know what's happening from the beginning. The cells are vulnerable. You know that there's a process going on long before it manifests as heart muscle weakness. And one of the advantages of cardiac magnetic resonance imaging is that it can see things. You'll see where the red arrows are there. That's the black area around the main pumping chamber marked LV. The black area, the wall with the red arrows, is showing scar tissue in the wall of the heart in that area, in a typical distribution. That will become evident before you have evidence on an echo scan that the heart is weakening. So one of the key things to understand is that long before there's any symptoms, decades before there's any symptoms, long before you have dysfunction, the heart is becoming affected by the lack of dystrophin. And the time to intervene, you can't expect to achieve much with the extreme panel on the right, but by interacting and deploying treatments much earlier, you're going to have a better outcome. So essentially what I'm saying to you is prevention is better than cure. That means getting ahead of things, and it's better getting ahead than always chasing after something that's stolen the march on you. And that means starting heart treatments before the heart weakens and increasing the potency of the regime once the heart begins to be affected despite those interventions. So you've seen this publication already. Following a 3-year process of expert consultation and reviewing the evidence, in 2022 we published this open access paper suggesting what heart involvement in the UK should be. We thought the international care standards were slightly vague and gave a bit too much wiggle room, and were accounting for some of the discrepancies families were reporting between what was available in one area or another. So we wanted to try and standardize care. And essentially, we recommended a 3-heart drug regime. So essentially an ACE inhibitor, a mineralocorticoid receptor antagonist, and a beta blocker, all working in different ways to support the heart and reduce the rate of damage. Now, of course, implementing these treatments in somebody who's asymptomatic from a heart point of view, you've got to be careful. You're not upsetting somebody, that you're not introducing side effects that weren't there before, and you've got to check certain regular tests that the kidneys are tolerating it, that the blood pressure isn't too low, etc., etc., etc. That goes without saying. But the important point is that it's not a question of saying, oh, maybe my boy won't get heart problems. It may be slightly different from the age somebody else got them, but they're only getting them at a slightly later age, not that they'll never get them. Now, when should these treatments be introduced? Well, the recommendations that we've made and published suggested that the ACE inhibitor should be started as early as the family are happy to do so. Now, that's slightly more aggressive than the international care standards, which says no later than age 10. Why is that? Well, because the heart in a Duchenne boy with sensitive measurements begins to diverge from their normal non-DMD peers from about age 7. We recommend that you add the mineralocorticoid receptor blocker on top of the ACE inhibitor once the patient is established and tolerating the ACE inhibitor well. That's an anti-fibrosis agent to reduce the amount of scarring. The beta blocker, or another drug of a different family, ivabradine, is used to slow the excessive heart rate that you typically see at rest in boys with Duchenne dystrophy. So these drugs are doing different things, but acting together increases the potency of the medication. Now, of course, during an acute illness, a boy gets a pneumonia, a boy has a fracture, needs treatment, needs surgery, then these drugs, some of them, particularly the ACE inhibitors, may need to be withdrawn temporarily. That doesn't mean that the treatment was inappropriate, just that temporarily during the crisis, they need to be withdrawn and restarted as soon as safe to do so afterwards. Now, this is the European International Care Standards document, recommendations for heart muscle weakness of all kinds. And you can see you have heart weakness, that's quite severe heart weakness on the left panel. In the middle panel, moderate heart weakness. On the right-hand panel, preserved heart function. But in brackets there, or circles, you'll see if there's evidence of heart involvement. So the DMD care standards we're recommending are consistent with this, which is applicable to other conditions and used very widely. The other point to make is that this is the effect of individual drugs. It doesn't matter what the drugs are. The ones I've mentioned are among the list here. But it's the effect of individual drugs used in isolation on cardiac mortality in heart failure or cardiomyopathies. And you can see that there's a range of potencies and they're different, which is why you want to combine them. You'll get better results. It's a bit like cancer treatment. One drug won't do it all. A combination of drugs gives you better results. It's the same logic for what we're talking about. And more recently, you'll see, especially once the heart begins to weaken and is obviously weakened on your scans or your schedule of scans, despite the earlier treatments, that a fourth agent is now recommended for the heart once the heart begins to weaken. That's an SGLT2 inhibitor, and some of the older boys that are receiving heart treatments may already be on that. And that's consistent with the European guidance. Now, what about drugs other than the ones I've mentioned? Over the last couple of years, another drug has become available, which is actually a combination of two drugs. It's like an ACE inhibitor with another oddly working drug associated with it. And it's been tested in children with heart failure in place of an ACE inhibitor. Enalapril was the prototype of an ACE inhibitor, one of the prototypes. And there's a vast experience with this drug now, sacubitril valsartan. It's very widely used. But there wasn't much experience in children, let alone in children with Duchenne. And the concern was that it might be too powerful for use in children with Duchenne. And the idea was, well, is it actually better in prophylaxis or at earlier stage in cardiomyopathy in children? We needn't go into the details, but you'll see there in the slightly bolder face, left ventricular ejection fraction less than 40%. That's a good going cardiomyopathy. It may still be asymptomatic, but there's no question but that that's moderately advanced heart dysfunction. And this was a study looking at children with all causes of heart dysfunction at that level. Quite a large number of children. There were similar adverse events for both enalapril, that's the older treatment, and the newer treatment, but they were both well tolerated. And in children, there wasn't actually a difference in the endpoints they had chosen, which is quite a complicated combined output between the two drugs. So at the moment, although in adults we believe that sacubitril valsartan is a more potent drug, we probably at the moment wouldn't be recommending it to replace the ACE inhibitor, certainly not for protective treatments at this stage. Another family of drugs that was originally designed for use in diabetes, the SGLT2 inhibitors, I won't even attempt to pronounce the full name for this, it causes a sugar diuresis. It was used to control sugar designed for that, but it was found to have beneficial effects on cardiovascular mortality as well. And it's probably acting through a whole range of, even excluding the hype that goes around this class of medicines when they were first launched, it's probably acting by an antifibrotic mechanism as well as causing prevention of gathering excessive water. In use in prophylaxis, that means before you have LV dysfunction, there is some trends for evidence of benefit earlier and earlier in its deployment, although that's controversial. So certainly once the heart becomes affected, it is something to be added in on top of the others. In prevention, there is a trend for benefit in that regard, but it's pulling together these 8 studies and sort of boiling down the data and seeing what you're left with at the end. So that's the reason why you may hear more talk about that drug as part of either treatment of heart weakness at an earlier stage or even in prophylaxis as the years go on. Now, of course, none of these medicines actually correct for the underlying problem, that's the lack of dystrophin. They do slow the effect of the natural history of weakness, and many of you will be aware of the attempts, the different ways in which trials are ongoing, and some of them are at an early stage of reporting, in the benefits of these attempts to replace dystrophin in the heart. I'm not going to go into these in any detail, but at the moment, and this is extremely provisional, extremely generalized conclusion, you'd say that they all work to some extent, but we're not actually seeing a massive change in what you might expect naturally at the moment. There are several limitations to these treatments. Some of them are already recognized, some of them are exclusion criteria for the trials and so on. Many unknowns, I won't say more than that. And what about this whole plethora of additional, more novel, differently acting drugs? Well, we have to find out, won't we? They're used in many other conditions, but of course there is a burden of tablets. We're already talking about 4 medications. Are we going to replace or substitute? How are we going to deploy these, even if we believe they're beneficial? You won't find in DMD trials specifically targeting swapping one out or adding another one. The population is too small, there's too much competition for recruitment to different trials. So you'll also be aware of other treatments like an alternative steroid, vamorolone, givinostat, another drug that's of benefit in skeletal muscle preservation. We have no cardiac information on these at the moment, and so we don't know what effect they'll be and whether they'll substitute for some of the more conventional treatments. So what are the take-home messages for you? Well, first of all patients with Duchenne dystrophy, all boys with Duchenne dystrophy develop heart muscle weakness. It's not a separate condition. All need to have their hearts assessed regularly to know how the heart is doing. Heart symptoms don't occur until very late in the condition. You've missed the boat completely if you've got cardiac symptoms, unless you've been getting all the treatments up to that point. Most adult patients with DMD die of either heart or lung problems. And the benefits of treatment are time dependent. So you can't make up in adulthood for what wasn't done in childhood. So let's be protective about the heart and get ahead of the natural history of the condition and make sure that the boys are getting appropriate heart assessments and timely treatment.